please, Professor Singer, we will now go to the next speaker, as we said, and we will have a look at what technology and what a lot of data can bring to us once again, both from a knowledge perspective, but also from clinical implementation. So please, Professor Singer, the floor is yours.
Thank you very much, Elizabeth, for your nice introduction. Thank you for Nestlé giving me the opportunity to present to you some advances in terms of machine learning and artificial intelligence regarding some of our big challenges today, how to feed patients. These are my disclosures, and definitively my main message will first recognize that we are confused by many of the papers that have been published recently, finalizing a big research with neutral results. And in the other hand, we have in our hands large databases, and we should try to find out what are the solutions using this database and trying to forecast what will happen to our patients and finding a better approach than only what we are recommending. I have to apologize about the guidelines. The guidelines are really a way to start and to try to prescribe the best nutrition. However, it is definitively a one-size-fits-all approach. We are not able in the guidelines to give all the different situations and provide to the practitioner what are the finesse of a nutritional approach. And the recent studies on energy, on protein, on glutamine, on selenium, or vitamin C, or vitamin D, or vitamin B12, you can see a lot of papers regarding different high dose or low dose that doesn't give anything. And therefore, Arthur is telling us we should do personalized medicine. On the other hand, you use every day your GPS to know what is the best way to reach your home or your work or your place. And sometimes you have to change your route and not to give always the same therapy like you are changing your route in your GPS. And Arthur and Elizabeth also wrote papers regarding personalized nutrition and include artificial intelligence in this. So we will join in this venture to climb the artificial intelligence problems and giving you a first appetizer of refeeding. Hypophosphatemia. Can we predict refeeding hypophosphatemia? And this is a nice paper published not so long ago, and comparing patients that are presenting hypophosphatemia during refeeding and those who are not, and looking to the features using a multivariate logistic regression analysis and a sham score, you can see that patients who have diabetes, patients who had a hypophosphatemia to start with, patients who had a weight loss, you can find the features of the patients that are at risk of presenting a hypophosphatemia when you start the feeding. You can see that we are changing now our approach to feeding. We don't prescribe and look what will happen. We are looking to different features and try to prevent what we don't want to happen. So we decided in our team to take the large database that we have, since we are paperless from 2000, so we have minute by minute thousands of patients in our database. And we looked, for instance, in this 7 years of database, trying to find out all the parameters that are existing in our database, the demographics and the lab and the nurse notes and the vital signs and the medications and the fluid, etc., looking to also the 3 or 4 main issues of nutrition: the route, the timing, the dose, how much protein, and the outcome, which are usually the survival, the length of stay, of course. So when we have this huge amount of data, what we do is to take a part of the data to make the training. 70% of the data to do the training, to run the training in the database, and to evaluate. And then we go back to the rest of the data, and we validate. So this is the way we are working. So to get the data is not easy. You have to be very careful with the data, not include everything. You have to clean the data. This is a lot of work. It's not just to not push on a button and get the data. You have to work on it. You have to process. You have to extract. You have to select. And you run then the model, and you get some algorithm, and you go back to the data, and you improve your algorithm, and you use other machine learning systems. And at the end of the day, you get something. And this something will try to help you to answer some questions. One of the first questions was to us, is feeding intolerance during enteral feeding an indicator of clinical outcome? And we found that yes, that in addition to the demographic data that we get usually from the patient and the Apache score and the SOFA score, when we add two parameters, which are the gastric residual volume and the inability to reach 70% of the energy target, we are able to better predict the 90 days mortality. And you can see the changes, not only ICU mortality, hospital 28 days, 90 days mortality, and length of stay as well. So two parameters related to the way of feeding are improving your prediction. The second question is more tricky. You start enteral feeding. The guidelines tell you early enteral feeding, let's start enteral feeding, and you don't know how it will work. You don't know if you will succeed. Is it a possibility to predict if you will tolerate or not, the patient will tolerate or not? So we looked at this, and we found that actually the GRV at day 2 was indicative of a possibility of failure in addition to the Apache and the SOFA and age, of course. And we looked a little bit more deep in that, and we definitively found that the day 2 of the GRV was a good information to predict the success on enteral feeding. We looked also to a large database, which is a nutrition day database that is also collecting thousands of patients all over the world, not only our single center. And we were happy enough to get this data and analyze them, and we presented this data in the last ESPEN Congress, and we found also that enteral feeding, and when you start the enteral feeding, is predictive of your tolerance to enteral feeding. Now, we were not alone to look at this. You can see here another paper looking to different machine learning systems to predict the success of enteral feeding. And in this data, you can see that patients who are suffering from sepsis, with a high SOFA score, with acute kidney injury and high fever, these are the patients that are the most intolerant to enteral feeding. Again, we are looking to not to give just because the guidelines are telling us, but we will try to find the best phenotypes for these patients that they will tolerate. Okay, now, we have to find out what are also which kind of enteral feeding we should propose, because we say that enteral feeding is something like is generic, but we have different formulas. This is a paper suggesting that when you use a 100% whey peptide formula, there was some better outcome regarding 30 days readmission in comparison to standard intact protein, a better GI intolerance, better tolerance to glucose as well. This has been summarized in this graph. So we decided to look at this as well. And in real life, you use enteral feeding, you may use a whey peptide, you may use a peptide plus another because you have to change, or you may use other formulas. And these are the populations that we were studying, which were quite similar in terms of Apache and SOFA, but not so much in terms of diseases. And we found that actually regarding the GI intolerance and specifically the GRV occurrences, if we put the RAF at 150, 250, 500, there is no change regarding the formula in the first week. But at the second week, there is a difference. And this difference is shown here. You can see that the symptoms are more frequent in the second week. And this is quite interesting because we were also always convinced that the first week is the time that there is the most occurrence of GI intolerance. So machine learning is another step toward personalized nutrition, and we have to learn it a little bit more. So here we summarized in this review the different papers at the lower part regarding the prognostic assessment. We did a lot of work on the enteral feeding intolerance, if it's helping us to know better about the prognosis of the patient or the residual volume levels, but also to predict patients with enteral feeding and with sepsis, what will be the GI symptoms to initiate the best time of enteral feeding. You can see that you have a lot of papers that are now accumulating to help us. Now, regarding enteral feeding, is it helping you when you start to enteral product because you choose some? Is it helping you? And the answer is yes. You can predict how much of feeding intolerance will happen when you choose some enteral feeding. It's, of course, after age, Apache, and SOFA again. But the enteral feeding is one of the features that is really leading. The gastric residual volume and the GI symptoms are also, of course, predictable. And you can see here that choosing some product will interfere with your outcome, not so much mortality, but hyperglycemia, which is significant, and use of prokinetics, which is a mirror of how your patient is tolerating enteral feeding. More you are using metoclopramide or erythromycin, more your patient is intolerant. So you can see here, in comparison to whey protein, the feeding intolerance is more frequent with other formulas or with when you have to change formulas, hyperglycemia as well, and there is a strong difference about prokinetics. So again, when you look to the prediction, enteral formula choice is helping you for the feeding intolerance. Hyperglycemia as well, and prokinetics, as I said, definitively you can see the differences. In the multivariate logistic regression analysis, you can see that feeding intolerance and prokinetics are really making a big difference when you choose a specific enteral formula. Now, we have this protein dilemma since we have more and more studies and meta-analyses telling us that we are not helpful when you choose a high or a low protein administration. And our guidelines are telling you that we should give 1.3 progressively, but the evidence is not very strong. And of course, not all the ICU patients are the same. Patients that are obese, patients who have sepsis, patients with renal failure, frail patients, multiple trauma, all these patients are put together in a study led by Darren Hyland and creating a large population and comparing high to usual dose of protein and giving no difference at the end of the day. However, it seems that patients that are malnourished have a worse outcome in comparison to the normal nourished. This was the only thing, this was a post-hoc analysis. We were inspired by some studies that were looking to not only the protein dose, but also the energy dose. Because you have patients that are receiving high energy and high protein, low and moderate. And it seems that the patients that were receiving low and moderate energy and protein had a better outcome than those who were receiving high and high or low and low. So we looked at this triad of route, dose, and timing in our large database, and we decided to look to this moderate energy group. And we decided to look to the moderate energy and compare them if they were receiving high protein or low protein. You can see that we had enough patients to compare, and we looked if they were surviving or not surviving. And we found that actually the phenotype of the patients that were surviving with high protein and moderate energy were younger, they had a higher BMI, they were less septic, and they had pulmonary comorbidity, which is a field that is not so much looked at. So you can see that not everybody is reacting the same way to a large amount of protein. Even so, he is receiving moderate calorie intake. And this may help us to maybe target better what we want to administer to our patients. Now we look to another part of patients which is in the acute phase but a prolonged way of stay in the ICU. And we took the recommendations of the ISICEM guidelines, taking a group of patients who had measured energy expenditure. Because all the studies that you look, the large studies, are not using measured energy expenditure. They are doing predictive equations. And you don't know if the energy that they are receiving is what they are requiring. So we looked to patients in our database that were staying longer than 10 days, and they were receiving more than 70% of their measured energy expenditure. And we compared two groups of patients, the patients receiving low protein and the patients receiving high protein. And here we can find a difference, a highly significant difference in survival when the patients are receiving high protein, but they have to receive more than 70% of their measured energy expenditure. And you can see here the patients were with a long length of stay, 19 days, 20 days. The age was quite similar, and the BMI was slightly different as well. And in the adjust Cox regression for mortality, we definitively confirmed that the amount of protein was significant here. So in conclusions, ladies and gentlemen, first, I am happy to be in time. Second, the AI is able to predict enteral feeding intolerance. And this is an important message because you can progress from a blind enteral feeding prescription to a better enteral feeding prescription, knowing that you will be successful or not. The ISICEM guidelines were recommending to start enteral feeding and to continue enteral feeding even if you have a GI intolerance, because I didn't want to start any parenteral nutrition up to 7 to 10 days. It may be not right because you are able to know in advance that the patient is not tolerant to enteral feeding and you have to switch your program or your target. AI is able to predict hypophosphatemia. You can find clusters of patients that will have an improved outcome when you give them more protein. This may be younger patients, less septic. Peter Weiss also showed us that septic patients are very resistant to protein. Higher BMI, you have more muscle, you can more metabolize the protein, and new comorbidities like pulmonary and cardiac have to be explored much more. So also, the use of 100% whey peptide seemed to be more tolerant for patients and decrease the use of prokinetics and hyperglycemia. So we should stop to react to failures. We should start to predict and to prevent. Thank you very much.
Thank you very much for this excellent presentation. And